Right. So in this particular case scenario, we're talking about pancreatic cancer. Okay. So in pancreatic cancer, the most common causes, as we are seeing, is a patient who's going to come with smoking, is a patient who's going to have hereditary pancreatitis, or a patient who's having a chronic pancreatitis, or your basically your lifestyle habits, right? So I would want you guys to know, when do you know it's a cancer from a pancreatitis presentation? Okay. So the same things between your itis and your cancer is that the patients can have your pain, the patients can have your diabetes mellitus, okay, but the more progression into pancreatic cancer is when they are going to be having the systemic symptoms of weight loss even more. Okay, so the cancer symptoms are going to be present over there, where you're going to be having your poor appetite, where you're going to be having weight loss. I think I have good amount of charge. Okay, so where you're going to be having weight loss, and where you're going to be having fatigue, weakness, okay, the appearance is going to be very bad. And the patients are also going to be having the presentation of hypercoagulability. Hypercoagulability presentation is what is your superficial thrombophlebitis, where a patient is coming with your Trousers syndrome. This is called as your Trousers syndrome. So when you have your superficial thrombophlebitis, Trousers presentation, like back to back, red color, tender, presentations with your pancreatic cancer, or when you're having thrombosis, when you're having thrombosis, when you're having thrombosis, or when you're having thrombophlebitis. Okay, so these are hypercoagulability case scenarios. The rest of the things are, the cancer can actually have your Corbusier sign. It's nothing but you have an enlarged non-tender gallbladder and a painless jaundice. Okay, so you have to remember, in a pancreatic cancer, the patient is going to be coming with sometimes the jaundice, if it is going to be happening because of the tumor in the pancreatic head. If you have the tumor in the pancreatic head, then your patients can come with an enlarged gallbladder, an enlarged non-tender gallbladder with a painless jaundice. Okay, so what is, I'll write it in a space where it's visible, or it should be given here. So when your patients are coming with this obstructive jaundice, the physical examination is going to have a palpable, non-tender, Corbusier sign. Okay, so these two are going to tell you that it's mostly commonly seen in your cancer case scenarios. Okay, and apart from the nausea, vomiting, weight loss, which is about how bad the patient's condition is becoming. In some patients, depression can also be a very prominent symptom. Okay, so now that you know, most commonly the thrombosis, where you do not know where the origin is coming from, could be a pancreatic cancer, or could be a pulmonary cancer, or could be a prostatic cancer. Okay, so that's why you have to remember, thrombosis can be because of the 3Ps. The 3Ps could be pancreatic cancer, or it could be pulmonary cancer, or it could be a patient coming with prostatic cancer, where usually we do not know where the origin is coming from for the thrombosis. Okay, so now it's important that in this particular case scenario, your epigastric pain, which is radiating to the back, or the patient coming with pancreatic insufficiency symptoms because you're having an obstruction by the tumor and the enzymes are not coming out. Okay, so either you're having the pain, or you're having a pancreatic insufficiency, or you're having pancreatic insufficiency symptoms, or the patients are coming with jaundice. Okay, or the patients are coming with jaundice. So these presentations are very common in all the pancreas presentations. Okay, so now when we look into the lab studies for the same, so ultrasound abdomen is the initial thing that we always try to do, because the patient is coming with a painless jaundice most of the times. Okay, in an ultrasound, okay, if the patient is jaundiced, you have to do an ultrasound. Okay, if no jaundice, then you have to do a CT scan. Okay, so this is very, very important. If the patient is presenting with jaundice, you have to do an ultrasound. Okay, so if you're going to see in the CT scan, okay, or in the ultrasound, what are we trying to see? CT is basically for staging. Okay, like how much of a spread is there? Okay, how much of a spread is there? How much of a size is there? Okay, and is a patient, if the patient is having a negative ultrasound, then you go for a CT scan. Okay, and if the patient's presentation is that they're having a weight loss and an abdominal pain, but you do not know anything else. Okay, so if you have a suspicion or you do not know anything else, then also you can do a CT scan. Okay, then also you can do a CT scan. So what's important here is, what do we find in these presentations? You know, pancreatic adenocarcinoma is going to be coming with a hypodense or a hypovascular mass. Okay, so the CT scan that you're trying to do over here, you're going to see a hypodense, a hypovascular, a hypoechoic mass. Okay, you see a hypodense, hypovascular, hypoechoic mass. That's the first thing. The second thing is your double duct sign. Okay, so double duct sign is that you have dilatation of two things. One is your common bile duct and your pancreatic duct. Both are going to be dilated. Okay, so you have to remember these are because you are having a tumor in your pancreatic head, which is blocking both the sides. Okay, so because you have a tumor in the pancreatic head, which is the most common area for your cancer, you're going to be having a double duct sign, which is bile duct and your pancreatic duct, both are going to be dilated. So what are our options in our imaging? You have ultrasound for jaundice patients, otherwise CT scan. Otherwise, if CT is not done, USG is not, if these both cannot be done, you have MRI. But in all these case scenarios, what are the findings that we look for? Hypoechoic, hypodense, hypovascular mass. Okay. Apart from that, a double duct sign. So irrespective of all these findings, if you want to do the markers, okay, the tumor markers, which is going to be calcium 99, okay, it's just a prognostic marker, okay, but we also have carcinoembryonic antigen, which is not that specific, but we can also use that along with your calcium 1919 if you're trying to do for screening processes, okay. So because the sensitivity and specificity is not that good, so we're not going to keep it as a confirmatory marker, but still we can do the 99 and the carcinoembryonic antigen together. So apart from this, we can also try to do other presentations, like we can do an MRCP if we want, or an ERCP if you want. So when do we do MRCP and ERCP? MRCP, if you're thinking the patient has a stone in the duodenum bile duct, that combination, that is your choledocholithiasis. And if you think that the patient is having a stone, that is choledocholithiasis. If the patient is having choledocholithiasis, then we can do an MRCP. ERCP is usually done. So if the patient is actually coming with biliary decompression, if it's indicated, okay, if we have to decompress, if biliary decompression is indicated, so in this case scenario, you have to do an ERCP. So now, apart from the ultrasound, apart from the CT, apart from the MRI, where we see a hypoechoic, hypodense, hypovascular mass and a double duct sign, we can also do a tumor marker, which is calcium 99 and carcinoembryonic antigen. We can also do an ERCP, MRCP. ERCP is for the biliary decompression, and MRCP is to look into the choledocholithiasis. These are extra investigations. The last case scenario, if you want to do a sampling or a biopsy, you can do diagnostic confirmation, that you can do a tissue sampling or you can do a biopsy. So that, but that's done with your endoscopic endoscopic ultrasound, whether you want to take the tissue sample or whether you want to take the biopsy. So now in this case scenario, if the patient is coming with, again, I'll repeat the labs over here. So apart from usual pancreas presentation labs where your patient is going to have jaundice, where the patient is going to have increase in your alkaline phosphatase, basically a cholestatic presentation because of an obstructive tumor, okay? The cancer 99, abdominal ultrasound and CT scan is the three investigations you have to remember. So now how do we treat this particular patient? Let's understand that we want to differentiate if the patient is uh, curative or if the patient is palliative. Okay. So now if we are looking into somebody who's coming with an endocrine tumor or whether it's an exocrine tumor, here I'm going to talk only about exocrine because I think it's pancreatic adenocarcinomas. Okay. So here what they're talking about adeno is exocrine. Okay. So endocrine will come to that. Okay. So in an exocrine cancer, it's mostly 95% of the time your ductal structures are basically involved. The next most common is going to be your acinar cells, your ductal carcinoma, followed by your acinar carcinoma, followed by your mucinous cystadenocarcinoma. Okay, cystadenocarcinoma. So you can either have an acinar adenocarcinoma or just an adenocarcinoma or mucinous cystadenocarcinoma. These are your three types of your pancreas exocrine tumors, okay? Adeno, acinar adeno, mucinous cystadeno, adeno, acinar adeno, and then a mucinous cystadeno. So this is dependent on your location. So if you're thinking that it's curable, who are the curable people? somebody who's on the stage 1, okay, or somebody who's on the stage 2 or stage 3. I'll talk about what is stage 1. So if you're wanting to say stage 1, anybody who's up to your T2, N0, M0 is going to be stage 1. Okay, I'll tell you. So no nodes, no metastasis. T2 is basically somebody whose tumor's diameter is less than 4 centimeter. Okay, less than 4 centimeter. So if you are going to be, so this is just one thing that I want you guys to remember, because you will have a differentiation whether it's curative or whether it's palliative. Anything that more than 4, anything that's more than 4, okay, and you have the lymph nodes, so then the patients are going to be coming with your surgical methods. Usually anything that's less than 4 centimeter, no nodes, no metastasis, then that's a curative option. Okay, then that's a curative option, because stage 3. Okay, so stage 3, we have to remember, for those patients are going to be coming with a presentation of T3 that is more than 4 centimeter. Okay, and stage 3 patients can have nodes. Okay, they can have nodes. If they have metastasis, it becomes stage 4. Okay, they start having the nodes and it's more than 4 centimeter. So now anybody who's till stage 2, when we are thinking it's curative, like potentially curative, we can basically do a surgical involvement or you can do a neoadjuvant therapy. Okay, so the first case scenario they're talking about is locally advanced or metastatic presentations, where that is your stage 4, where palliative therapy is the only thing. But if the patient having a small tumor in the pancreas with no metastasis and no major vessel involvement and no lymph node involvement, so those are the patients who are till stage 2, where you have to go for a Whipple's procedure. So Whipple's procedure is you take the head out, okay, you take the distal stomach out, you take the duodenum out, you take the gallbladder out, you take the common bile duct out. Okay, you remove all these things. So Whipple's procedure is a case scenario where we are taking the pancreatic head out, distal stomach, duodenum, gallbladder, and common bile duct. Okay, you're taking all of these structures out. So you're doing a pancreatic or duodenectomy. Okay, you're doing a pancreatic or duodenectomy. And of course, if the usually this case scenario should not have lymph nodes. If they're having lymph nodes, you have to take it out. Okay. So now that is your head carcinoma, but something in the body, you have to do a splenectomy also. Body or tail, distal pancreatomy with the splenectomy. Okay. So anything that's up to your presentation of stage 2, anything that's your up till your presentation of stage 2. Okay. So you have to remember, in this particular case scenario, a patient is going to be going for a curable disease where we try to do a surgery. Okay, so anything that's more than your stage 2, okay, like we go for palliative therapy. Palliative therapy is just chemotherapy. Okay, so in chemotherapy, we basically have neoadjuvant therapy and we have adjuvant therapy. Okay, so in your chemotherapy, we have to remember the options that we have is going to be FOLFIRINOX. Okay. Otherwise, we can also have options with 5-fluorouracil. We can also have options with gemcitabine. Okay. We can also have options with paclitaxel. Okay. So these are all going to be your options. These are all going to be your options. Okay. But palliative therapy, you should also know how to relieve the pain. Okay. You should also know how to relieve the pain. So you can either do an ERCP with stent, or sometimes we also do a celiac ganglion block. Okay, we can also do a celiac ganglion block. Okay, so, and you should also remember that if a patient is coming with splanchnic nerve, okay, that's being the problem, so then you can also do a splanchniectomy. Okay, so the last three options that we have is putting a stent or the celiac ganglion block, where you're trying to reduce the you destroy the nerve tissue by putting ethanol on it. Okay, you destroy the nerve tissue 98% by putting ethanol on it. Okay, so and then you can also do a splanchniectomy, where you're trying to section your splanchnic nerve to interrupt your pain conducting nerve fibers. Okay, so these are going to be your options over here. Okay, I think